Thank you very much, and apologies that I wasn't able to be here earlier. Yeah, I'm a consultant psychiatrist in a eating disorder day service in South London, and I've just finished reviewing someone 5 minutes ago, and I had to tell them, and I said many apologies, I have to present now, and but anyway, I managed to wrap things up again a little bit. So I've been doing an MD Res. I'm very thankful for the funding from Mental Health Research UK. And my title is a mixed method study investigating the role of self-compassion, the therapeutic relationship, and the phenomenology of psilocybin therapy for treatment-resistant depression. Psilocybin is part of the family of classical psychedelics, along with mescaline, LSD, and DMT. You can see psilocybin here in the top right, in the form of psilocybe mushrooms. So all of these drugs act on the serotonin, on the 5-HT2A receptor, and all cause fairly similar altered states of consciousness, which last for differing states of time, so different amounts of time. This is another picture of the Liberty cap, which is a mushroom found in the UK that contains psilocybin. So just to think about the word psychedelic, this was a term coined by Humphrey Osmond, a British psychiatrist in the 1950s. He used LSD for alcohol dependency. And psychedelic is the sort of Greek meaning of mind manifesting. So these psychedelic drugs, compared to sort of when you think of other illegal substances that tend to numb the mind, these kind of drugs are bringing manifesting the mind, bringing whatever is in the mind, bringing it up to the surface. This is just a slide showing that the psychedelic effect is mediated by the 2A serotonin receptor, that when you antagonize this, that you don't get the psychedelic effect. This is a diagram from David Nutt to show how the physiological harms of psilocybin here on the very right under mushrooms is very low compared to other drugs, like particularly on the left, like alcohol and heroin. But obviously there are still harms. So we have to be mindful about this. So my research is looking particularly at this idea about the set and setting in which psilocybin is given. Stanislav Grof is a Czech-born American psychiatrist who's a sort of father of transpersonal psychology. He developed ideas about set and setting in the 60s and 70s, and he coined the term non-specific amplifier, that essentially when you take psychedelic, that whatever is in you and in the environment around you will be amplified. So there's this basic assumption that the set, which we call the mental state and traits, as well as the expectancy, intentions, and personality, plus the setting, so the kind of interpersonal contact you have, the physical space, the music, the kind of lying in bed, will affect the kind of dosing experience you have. And these are a kind of underdosing experience here. You can see different types of different ways that experiences have been conceptualized, experiences that are thought to have been helpful to improve mental states, whether it's in depression or other mental disorders as well. So I'm particularly interested in how the interpersonal contact with the person that you take psilocybin with, known as the guide or the therapist, how that contact, that relationship is going to affect the outcome, how it's going to help to improve people's depression, as well as to look at whether thinking about the dosing experience in terms of experiences of sort of increasing, having experiences of compassion, which then can help to increase someone's ability to be compassionate towards themselves. Treatment-resistant depression is associated with people having high level of shame, and this can mean that sometimes it's sort of, this is like the kind of opposite idea of self-compassion, the idea that somehow as a person it's your own fault, you kind of are the person to blame, rather than being able to kind of have the perspective to see yourself as someone suffering like others and to be able to give yourself what you need. So it requires further research, and this is what my kind of my thesis is looking at. Just quickly going to take you through what the psychological support looks like with psilocybin. It's split into 3 phases. It's a non-directive support, and its emphasis is very much on establishing a highly attuned rapport with certain therapist qualities such as humility, kindness, openness, trust, empathy, gratitude, and authenticity. And William Richards has written a lot about this. He's a therapist in America who's done a lot of work in trials there. So the preparation phase is about establishing a strong therapeutic alliance, about giving psychoeducation about what might happen during dosing, and practicing a kind of present moment experiencing, as well as setting an intention for the experience. These are the kind of mantras that we use. It's this idea about going into things, about experiencing all that comes and that all is welcome, rather than a kind of avoidance or a sort of a fear of looking at things. So these are the kind of things that we ask patients to remember. Patients arrive then for the dosing in the morning, and it's essentially a kind of 9 till 5 activity where they lie down in a bed, and we put on the music. They wear eye shades, and it's very much that people will stay like that without there being that much interaction with the guide. However, we will at times use something called interpersonal grounding, which is where you hold someone's arm, and this is something that we talk about in preparation in terms of informed consent, because obviously touch is a highly potentially triggering area. We use different music. This is some examples of the music we use. I'm just going to whiz through. Integration then is normally 3 sessions roughly, and it's about making a meaningful narrative about the dosing experience and how that helps them maybe have new perspectives on their depression and going forwards. So I did some qualitative research on a trial quite a few years ago at Imperial. This one in the middle, patients' accounts. And what I also noticed is there was a lot of experiences of self-compassion that were happening that hasn't really been looked at in the research so far. So I really wanted to, you know, my aims are to find out, does psilocybin lead to increased compassion? Oh, sorry, that's meant to say experiences during. Oh, no, yes, sorry. Does psilocybin lead to increase compassion dosing experiences? Does it lead to increased self-compassion states? And does it lead to increased self-compassion traits as opposed to placebo? And my, so, just trying to think where to go next. So I've been looking at these in the CIDR trial at King's College London, headed by James Rucker, my supervisor, and it's just finished. I thought I was going to be analyzing this data maybe last year, but the trial is only just finished and it's still awaiting like locking of the data. This is a scale that also in the meantime I've developed and we've given to these participants. I've talked about the development of this scale, I think, another year. but anyway, I'll be looking to see whether this, as compared to placebo, people's experiences of compassion as rated by this is higher. Then I'll be using this scale to look at self-compassion trait scale, and another scale, which is a state scale that I've adapted from this scale, looking to see whether that has also increased compared to placebo. Then I'm also looking at the therapeutic relationship. Is a better baseline therapeutic relationship associated with greater improvements in depression after psilocybin? Using this scale, the STAR D scale, STAR P scale. There is also a STAR C scale, which is given to the clinicians. And then I'm doing an exploratory analysis where I will be looking to see if I can, so if there are correlations between these different, the therapeutic relationship at baseline, compassion experience factors, increased self-compassion and reduction in depressive symptoms as measured on the QID scale and the Maudsley visual analog scale. And if there are, where there are appropriate correlations, to then do regression analyses, and then hopefully to try and do a serial mediation analysis. And my hypothesis is this would be the sort of direction of travel. So I've registered my my analyses on OSF. And I'm just awaiting for the the data to be locked so I can start doing the analysis. I've also, I haven't talked about it in this talk, but I have a qualitative side to the to my thesis in which I'm looking at self-compassion and therapeutic relationship, but I'm also looking at the phenomenology in general, and also looking at it from the perspective of the patient in terms of like trying to optimize the context. You know, what do patients have to say about what's helpful and what's not? So this is my deadline now. So it's just gone off the bottom of the page, is this 4th of May 2026. So I will be going into pending submission status on the 4th of May. And this is my timetable. So just, yeah, I just wanted to say thank you so much to Mental Health Research UK and for everyone here who's been involved in financing my MD Res. And I want to say thank you to Ian, who is an expert experienced in the PPI board of the CIDR trial, who has helped to pilot my interview schedules. I want to say a big thank you, and I really wanted to be here earlier for the tribute to Claire. I'm really grateful for her kindness and support of me during my time of doing my MD Res, and there was a point where I wasn't sure whether I was going to be able to continue because of the busyness of my job, and I have 2 small children as well. And I sent her an email, and I just want to sort of, this is the email she sent back, and it was just such a wonderful email to receive. I felt so supported, and I think there was something about this email that really helped me to also actually continue doing it. Yeah, thank you to Claire, and I'll end there.